My name is Megan Young, UA Manager with Med-Rok Systems, Inc., and this is TechMed Talk, where we discuss current and emerging healthcare tech with healthcare professionals. Today, we will be examining the benefits versus shortcomings of electronic health records on the healthcare professional and emerging AI-like tech solutions with Rachel Phillips, RN, BSN, founder of Med-Rok Systems, Inc. Good afternoon, Rachel. Tell us a little bit about your background.
Well, good afternoon, Megan. I've been an ICU ER nurse for 25 plus years, working in hospitals, post-acutes, home health, and with insurers such as Anthem, Blue Cross, Blue Shield of California, United Optum, also with third-party administrators who manage self-funded groups. Founded and ran an independent case management company, Priority Healthcare Case Management Services in Los Angeles, for about 7 years, after which, and because of the experience during that time, I founded Med-Rok Systems to develop what is now patented healthcare software.
Well, why don't we start out by getting your perspective on electronic health records and the benefits versus challenges for healthcare professionals such as yourself.
Okay. Well, I can tell you that I was an actual ICU ER nurse when paper charts were being used and before electronic health records were introduced. And when the rumors went around that they were introducing electronic health records, we were actually pretty excited because we thought that this technology would standardize the documentation. It would allow us to avoid the errors involved in physicians' handwriting that sometimes took 3 or 4 of us standing around holding the paper chart upside down, up to the light, because we couldn't figure out what the physician in his own handwriting had ordered for the patient. So we thought there'd be a great deal of organization. And they basically touted interoperability and interconnectivity, which, as we all know, has been missing from healthcare since its inception. So the perceived benefits at the outset of them introducing electronic health records were pretty exciting. What I would say very quickly realized was that instead of the paper charts, for example, in ICU, we had, it was almost like a map, unfolding a map. It was a huge piece of paper that we kept at the foot of the bed of every patient. And the chart, you would, be with your patient, and then you would go to the foot of the bed, and it would take you seconds to chart their vital signs, their blood gas results, glucose, if you administered a medication, and then you would just turn right around and attend your patient. So I would say at that time with using the paper, we spent 80% of our time with the patients and about 20% of our time with charting. So, when they brought out health records, we thought, well, surely that's going to be reversed, and that we'll probably have another 10% time to share with our patients. Unfortunately, it was just the opposite. We began to realize that we were stuck behind the computer and on the keyboard for 80% of the time and only had 20% of time to attend to the patient. We called that the 80-20 phenomena. And that hit us like a brick, actually, where ICU nurses had to stay over 2 hours just to catch up with all of the the typing and documentation. The second thing we noticed was that there was no interoperability or connectivity provided. In fact, these large corporate electronic health record companies further isolated the industry. For example, Epic is one of the largest and the first electronic health records that came out. Any hospital group that would use Epic it did not communicate with another health group or health hospital group that used Cerner or Allscripts, et cetera. It didn't include the whole health team on the system. For example, insurers still weren't on there. Primary care physicians weren't on there. Ambulance companies weren't on there. And it really didn't provide any interoperability or process automation at all. The other thing that became quickly apparent was the quality of care that we thought were going to be enhanced by electronic health records was very disappointing and disconcerting, because physicians began to save time in documentation again so they could attend to all of their patients and families. They started copying and pasting. So in the paper charts, you could open the chart and the current issues were on the top. There was no copying and pasting. You knew exactly what was going on with the patient within seconds. Now with the electronic health records, they started copying and pasting for weeks at a time. So I could look in an electronic health record and it would take me 45 minutes to figure out what is current. Did this happen 3 weeks ago? Did this? So you can imagine the safety issues that occurred because are still occurring because of that. So bottom line, the last thing was there was no process automation. There was no interoperability or connectivity. So many healthcare professionals are so disillusioned and burnt out because they've become their own secretaries in a sense. So that's it in not quite a nutshell.
Okay, so how does outside industry tech provide solutions for the healthcare industry?
Well, that's a good question, because that's exactly how we started out when we realized we need a solution to put healthcare professionals back at the bedside so they can interact with the patient, the family, so the healthcare team could interact together instead of sitting isolated doing all this typing all day long. So we examined outside industry tech juxtaposed against the outdated healthcare industry and realized that when you look at tech such as Expedia, Trivago, Amazon, eBay, and Uber, they actually connect industries on a unified platform where not only all of the, for example, with Expedia, it's flights, hotel rooms, reservations, restaurant reservations, vacation packages, car rentals, and the consumer all on one platform. And they can interact in real time. You can book a hotel. You can cancel the hotel without a single phone call. So we realized that why aren't we using this type of technology in healthcare? And again, the processes on these outside tech are automated, where they decrease phone calls, delays, expense. So that was our first aha moment when we realized that there's not a single unified platform in healthcare where all users are on the same platform and can communicate in real time with no integration requirements. The other thing I mentioned was that process automation, meaning such processes as moving a patient from a hospital to a post-acute, or when in admitting the intake of a patient, where you find out immediately if the patient is in network or out of network, and returning them to in-network facilities. The process of receiving even concurrent insurance authorizations for payments, et cetera. So we looked at that, and again, that was our big aha moment, that we needed to start providing this kind of technology for healthcare.
Okay, so what healthcare processes are you targeting with your software?
Well, first of all, we realized that over 30% of the over $4 trillion we spend on healthcare annually is due to wasted administrative costs and the disconnected entities in our system. And we decided to look at we found out and identified 7 different processes from admission to home biometric management that was involved with this 30% waste. And I'll just give you a few, like AdmitScan is our first, which actually is a definitive solution to surprise billing during the admission process and returns patients back to network quite quickly. We have automated nursing shift report, which digitalizes the bedside nursing shift report and provides automated case management capabilities, letting the healthcare team know of all the real-time issues that need to be addressed so nothing's missed, improves the quality of care. Also, out of the automated nursing shift report comes the automated insurer authorizations, which on a daily basis can assess using industry standards or equivalent to industry standards, whether a patient meets for inpatient level of care or lower levels of care. The 5th was the automated claims. I think the 6th is Transpedite, which addresses moving a patient from the hospital to post-acutes or lower level of care beds. And the 7th, is the home biometric management. So just so you know, Transpedite and AdmitScan are market ready, and we're now introducing Transpedite, the newly patented Transpedite, into the industry.
So let's talk about Transpedite. What processes does it address, and what are the financial benefits to your solutions?
Transpedite addresses the process, and I should say the delayed process, an expensive process of transferring hospital patients to post-acute beds, home health services, acute rehab, inpatient psych, and shelter beds. Just so you know that, as soon as an insurer, when going back to those authorizations, as soon as the insurer, case manager, utilization manager ascertains that the patient no longer meets for inpatient care, they stop payment. So when that patient is sitting in the hospital for days, sometimes weeks, when they can't find a lower level of care bed at either a long-term acute, subacute, or skilled nursing facility, they're losing up to $3,000 to $12,000 a day. And again, because the hospital case managers are extremely busy, they use support staff to provide, all these phone calls back and forth, trying to find an available bed in a facility that provides those services. Hospitals lose over 25 to 30 million annually in losses related to this process.
Can you discuss the current manual process of transferring hospital patients to post-acutes? That led you to identify this is a problem that required innovative solutions.
Well, having been involved in this process intimately as a hospital case manager, I can tell you that this process decades ago started out with what we used to call basically faxing. We just faxed it to individual facilities, not knowing whether they had an actual open bed, not knowing for sure if they provided the services that were required. And we faxed raw medical records. So, it created a high workforce for us and a high workforce for the facility staff, because they would have to try to figure out what was going on with the patient, if they had a trach or didn't have a trach, etc. And that evolved into what we call that was the first quote unquote innovative jump, was pulse faxing raw medical records indiscriminately to facilities, which now you could fax to 100, with eFax to 3,000 facilities raw medical records indiscriminately. But that didn't solve the problem because, in fact, it worsened the problem because, again, now you have even more facilities that either didn't provide the services that were necessary. You would get thousands of phone calls a day. What is really going on? Do they still have, 3 IV antibiotics? Do they still have this? And we don't have a bed. And when are they going to be actually discharged? Because at that time, we were faxing sometimes up to a week before the patient was ready to be discharged, which that is just really a waste of time because a patient's clinical status can change overnight. So that was causing a lot of unnecessary work and phone calls and delays. After the pulse faxing, now when electronic health records came into being, they actually just digitalized that pulse faxing and changed it into pulse emailing, where you could take the records digitally, put them in a queue, and then again, pulse email them instead of the pulse faxing. And everybody thought that was going to solve all the problems and the delays, etc. It didn't. It was just digitalizing a failed, quote unquote, solution where you're indiscriminately emailing raw medical records to facilities. And again, sometimes a week in advance. So that's what we took a look at. And sometimes when I talk to people about Transpedite, they'll say, well, electronic health records solve that problem. No, they don't, because again, the phone calls are still necessary. The delays are still necessary. The clinical, what I would say, the poor clinical management is still a problem. And it doesn't stop all the delays in the discharges.
And how is Transpedite an improvement from current processes such as what electronic health records provide?
The way Transpedite works is just like, again, going back to outside industry. Transpedite works by allowing facilities to enter their available beds in real time. And that would be by gender, by how many beds are in the room, by isolation. And again, a lot of times it's very difficult to find isolation beds for patients who have multiple isolation issues like MRSA sputum, VRE of the urine, C. diff of the stool. So that's the first thing is real-time entry, just like you would put a hotel room on that has 2 beds or 1 bed, that has a jacuzzi or not, that's non-smoking or smoking, or provides a facility that, a hotel that provides free breakfast in the morning, or that's located near certain restaurants or certain conferences, etc. Well, that's what Transpedite allows these facilities to do, is to put these actual open beds on the system. Now, along with that is provided what we call a capture profile. So in order to ensure that a patient referral is with the matching of that patient referral to that bed, we also want to make sure that the services required by that patient are provided at that facility. So we create a capture profile that includes very detailed clinical information, whether they provide wound vac care. Some SNFs don't have nurses trained to do that. Whether they'll take a trach, again, LTACs and subacutes will take trachs, but SNFs won't. So that's the first thing that it provides. On the hospital's end, it allows a case manager to quickly, within 2 minutes, by radio buttons, click, 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 what services those patients need. Do they have a trach? What percentage of oxygen if they're on a ventilator? Do they have a wound vac? How many IV antibiotics? When they put that referral on the system, that capture profile from the facility only grabs cases that are appropriate to the bed and the services. So that's the first thing, is it's not indiscriminately faxing or emailing to multiple facilities, which, if you really think about it, is a HIPAA violation, because facilities that don't have an actual open bed and don't provide the services, do not meet that need to know basis for HIPAA compliancy. Now, our system allows that, where it's not going to indiscriminately expose confidential patient information to facilities that don't need to see it, or that could accidentally expose that to other entities. So, and the other thing is it's completely automated. It's not just that it matches. Once these referrals on the hospital end and the capture profiles are put in the open beds, it 24/7, it continues grabbing cases, either grabbing referrals for the facilities or grabbing facilities and beds for the hospitals. And once those matches are made, a series of interactive status exchanges occur. Just again, like you would order or confirm you're taking that hotel room. So would the hospital confirm they'd make a bed claim? If the transfer is canceled, the hospital, all they have to do, they don't have to make a phone call to let them know. They would just basically click on cancel transfer, and the facility would be informed of that, and their bed would be opened up to other case managers at other hospitals that are vying for that bed. It's all, if you have to ask for a short-term hold, again, you just do that electronically. If you want to, so at any time, the statuses can change. The other thing is that it offers automated authorization. So a lot of times when you're transferring a patient out of the hospital, it can take up to 72 hours to get a SNF, a skilled nursing facility or LTAC authorization. Our system actually uses intelligent algorithms that are equivalent to industry standards that can say this patient meets what we call SNF, skilled nursing level, because they were independent before they came into the hospital and had the stroke. Now they can only ambulate 20 feet with a front wall walker, and they have one IV antibiotic. They don't have appropriate or safe options for home. So our algorithms will authorize that patient for an initial 7 days within seconds. So again, you are cutting off 72 hours of delay at best. Sometimes it takes up to a week to get those. So that, and then you're ordering your ambulances online, what should I say, on Transpedite, where, again, there's no phone calls. If you book an ambulance and then you cancel it, no phone calls, just do it online so the ambulance company will know. You can reschedule it. And also on the facility side, they can go ahead and cancel a bed, et cetera. So it's all interactive, including what we call secure chat. So, for example, if a culture result needs to be added to the case, they can just write, send that, please attach that culture. Or they can write, can you send that patient at a different time? So 100%, no phone calls, emailing, or faxing necessary with Transpedite. Now, in the future, once we introduce this into the market, there's home health, setting up home health care, even for IVs at home. It's going to be for acute rehab. Another area that's difficult to find is inpatient psych. I know as an ER case manager, there were many times a patient sat there for over a week because we could not find an appropriate inpatient psych bed. And shelters. Instead of having the social worker having to jump through hoops to try to get this patient at an appropriate shelter or recuperative care, Transpedite allows that as well. And lastly, there's also telehealth. If you have a patient that's a high-risk readmission, you can book that telehealth follow-up right there on Transpedite, and or you can book their follow-up appointments. So it's a pretty much full service type of system, our application.
So, and what are your plans to introduce Transpedite into the market?
Well, we've had interest from, first of all, I'll tell you, we went to Boston in 2019 to the Blockchain and Telehealth Conference, which had a pitch contest, which that was all physicians there. We actually won that pitch contest with Transpedite, and the physicians there were really kind of I would say, shocked that we are not using this type of technology in healthcare. And the other thing is, we also won at the Founders Institute. We won, Transmedite also won that pitch contest. But right now we're approaching hospitals, post-acute facilities, large insurers and medical groups, IPAs, and really wanting to do a pilot, should I say, industry pilot initially. And that's really the stage that we're at.
Well, that concludes our podcast today. We look forward to continuing this discussion in our next scheduled podcast, Origins and Evolution of Case Management on TechMed Talk. Thank you so much, Rachel, for your time.
Well, thank you, Megan. It's been very interesting. Thank you so much.